Okay, welcome back, everyone. And to those of you who are just joining us, welcome to the CDC workshop on applied epidemiology and environmental health. This is will be the second presentation by Dr. Michael Goodman. And he's going to talk to us, share his expertise about cancer cluster investigations, a few thoughts and suggestions. Just a little note here before he begins, and also I'll give you a little background about Dr. Goodman. But as many of you know, CDC has recently developed a draft document with guidelines for examining unusual patterns of cancer and environmental concerns, which is an update of an earlier related guidelines on cancer clusters. The purposes of this presentation and the workshop differ from those of the guidelines, although of course there are overlaps. Our purpose here is to present and discuss, or Dr. Goodman will present and discuss practical methods in epidemiology for identifying an initial evaluation and further investigation of suspected cancer clusters. The emphasis is on his perspective as a scientist and on practical considerations and applications. So Dr. Goodman, and I'll turn the floor over to you, Mike, so you can share your slides in just a second, but Dr. Goodman is a professor of epidemiology at the Rollins School of Public Health here in Atlanta. His research includes a broad range of topics relevant to epidemiology of non-communicable diseases such as cancer, endocrine health, mental health, and much more. He has experience in all aspects of epidemiologic research, including study design, implementation, data analysis, and has served as the principal investigator of multiple studies that involved quality of cancer surveillance, the role of oxidative stress in colorectal neoplasia, and much more. So with that brief and inadequate introduction, I turn it over to you, Mike. And welcome you, and you are muted.
I know, I was just fumbling here.
Okay.
Thank you, Dana, very much. I must confess that this is an issue that I haven't looked at in detail for a number of years now. So it is possible that some of the information that I'll be sharing is not necessarily up to date, but following this topic a little bit from the periphery, I think that many of the issues are persistent and they've been around for decades now. If past experience is any indication, I suspect some of the challenges that face cancer cluster investigations or cluster investigations more broadly probably apply today as well. Let me share my screen and I will proceed with sharing my thoughts with you. All right, you should be seeing the full screen right now. I named this topic A Few Thoughts and Suggestions because I do know how much work goes into developing CDC guidelines, and I've looked at the most recent draft of the document. I think it's a very good and nuanced and comprehensive document that understands the complexity of this issue. So again, it's a bit of a 30,000 foot view of the issue rather than an attempt to provide you with detailed guidelines. Now, I suspect the reason that I was invited to give this talk is because back in 2014, that's 8 years now, I was a member of the very interesting workshop that included a lot of people from different walks of life and different areas of expertise that were interested in this particular issue, cancer clusters, sort of trying to understand where the science stood at that time and offer a few suggestions for how one might tweak our thinking about this very complex issue. This was a disclosure. This was supported by the, I think now ceased to exist, Research Foundation for Health and Environmental Effects, which received contributions from chemistry industry. But and some of our participants received honoraria and some received travel support, but not all. And the paper that came out of that workshop, as I mentioned, includes people with co-author, people who really have done investigations themselves. Some of them work for state health departments, some work for NIH, some work for cancer registry organizations, and some are from academia. And so what I will do, I will try to extend the conversation that we started back then. So first question, why conduct cancer cluster investigations? And you can replace cancer cluster with other cluster, non-communicable cluster investigations. Cancer is probably the most common example of a condition that attracts attention with respect to its clustering in time and space. But there are other non-communicable diseases that may also be the subject of investigation. So first job, of course, is to confirm the existence of a cluster. Statistically confirm that what seems to be an increase in frequency of a particular condition or particular cluster is truly something that's above and beyond expectation. The very often the mandate or the desire is to understand the cause of observed cluster. But just as important and based on my review of the literature and what people who really work on those issues, is just as important to stay engaged with the community, to take for the health public health organization, take the lead in terms of educating the public and making sure the public is fully aware of what's going on. You know, if one were to look at cluster investigation as a causal endeavor, as an attempt to understand etiology of disease, or previously unknown cause of disease, then one must admit that there many of them, most of them, vast majority of them have not led to an identification of specific causes. So this is another paper that preceded the one that I told you about by about 2 years, where a smaller group of us looked at publicly available reports of cancer cluster investigations across various states, as well as those who were available from ATSDR and other federal organizations, as well as peer-reviewed literature. And so we tried to contact each state and ask them to share whichever reports they were at liberty to share with us. And we also canvassed the websites and various repositories that are publicly available. What we found is there were close to 550 or so distinct investigations. Some of them would be in the same report, but the distinct investigations, there were 567 to be exact. And there are some states that conducted hundreds of them. Illinois and Texas are examples. There are some states that, as far as we are concerned, did not have any such reports. Some states do not conduct investigations, but an occasional investigation was available either from peer-reviewed literature or from federal sources, such as ATSDR. And so of those 72 there was statistical confirmation that the frequency of a cancer is above expectation, usually with a conventional cutoff for what is considered statistically significant. And then in-depth investigations identified 3 clusters where there was an association, even though researchers in 2 of those instances stopped short of drawing a causal conclusion. In one instance, the causal conclusion was unambiguous, even though, that particular case, I don't think we'll learn a whole lot from that particular cluster investigation. This was a residential cluster of pleural cancer, mesothelioma, which happened to be in South Carolina in the close proximity to shipyards. So it was clear that the cause of that was occupational and perhaps non-occupational exposure to asbestos. And no known cause of pleural cancer, of course. So anyway, be it as it may, this was where the data stood about 10 years ago, and that's based on 20 years of data that we reviewed. And the reason we picked 20 years, because in 1990, for those of you who are interested, you may still locate, there was a special issue of American Journal of Epidemiology. That's 30 years ago, more than 30 years ago, that looked at various aspects of cancer cluster investigations, or more broadly, cancer investigations. And so that issue, I think, will raise some of the problems, or mention some of the problems that I think we still face today. And those problems, especially as it relates to cancer, may fall into 4 categories, broad categories. One is that for most cancers, not all, but for most cancers, especially solid cancers, there is a long induction period that needs to be considered. So if one were to think of a clustering of a cancer, one also needs to be thinking of a clustering of its potential cause. And that cause may precede the onset of disease by a decade or more, maybe 2 decades or so. This does not include pediatric cancers and cancers with relatively short latency period, like pediatric leukemias in particular. But most cancer investigations are related to solid tumors. And so that's an issue. The other one is migration. Where people live now doesn't mean that they live here several years ago. People move around, especially in a country like United States, where there's a lot of mobility. Boundary definition is an interesting statistical issue. The borders that are drawn for administrative reasons may not necessarily correspond to the borders of the cluster, so to speak. And so when we're tethered by the boundaries that exist on the map, we may be missing the true clusters, or vice versa. We may create clusters where no cluster actually exists. And then with respect to cancer, I think we've learned, especially in the last decade or so, that our traditional tools for cancer classification, the International Classification of Diseases for Oncology, 3rd edition, that's still being used for cancer surveillance, may group cancers into categories that do not necessarily reflect reality, so to speak. In other words, you may have cancers arising from the same site, but very different in nature. Or you may have cancers from seemingly different sites that are united by common oncogenic events. So what to do? What are the possible avenues to pursue? And I admit that it may not necessarily be within the scope or mandate of a state health department, for example. Nevertheless, just something to think about. So first is reconstruction of residential histories, trying to understand not only where people live now, but what the history of residents, how the addresses change over time, what type of exposures they may have experienced sometime in the past. There are novel statistical approaches that disregard the existing administrative boundaries, such as counties or census tracts, and try to understand the clustering sort of in its pure agnostic form. And I'm not an expert on that, but you do have an expert who will be talking about some of those issues coming up. So I would gladly defer to him. That's Dr. Lance Waller. I think he's scheduled to talk tomorrow. Alternative grouping of cancers, I think, is a very interesting possibility here. So in other words, instead of trying to group cancers based on where they originate from, which organ, or even based on histology, there may be an opportunity to examine molecular or genomic features of cancers. And if so, the groupings that we are used to employ may not necessarily work well if we're trying to understand clustering of, so to speak, causes as opposed to clustering of events. And finally, the exploration of newer, I emphasize newer hypotheses, because some of those hypotheses have been around, again, for a long time, but they seem to be underrepresented. At least they seemed to be underrepresented last time we looked in the sort of among the working hypotheses used by cancer cluster investigators. So now what I'll do, I'll just share with you a few papers. Some of them are relatively recent, some of them are dated, but nevertheless relevant, that talk about those various ways of addressing these issues. So first, with respect to residential history, we now have an opportunity. For those of you who work in, say, cancer registration, you're well familiar with that. We now have the opportunity to access population directories that are commercially available for subscription, such as LexisNexis. And LexisNexis allows, or at least allows to attempt, reconstructing not only current addresses, but also past addresses for a given individual. Now, there's a lot of issues that may be related to confidentiality and sort of IRB approval of that, because the study that I cite now, there are several other studies. They usually do that because they have explicit consent from participants to access LexisNexis. But nevertheless, it is a possibility, and so you can see that in addition to looking where people live now, LexisNexis or similar population directories allow you to reconstruct where people lived in the past, and maybe going as far back as a decade or two. This is certainly a tool that is available already, and I suspect it's only getting better as far as the usability. The cluster detection, a simple metaphor that I would use in trying to explain what the novel methods could be is, if you imagine a tiled floor and you spill a bag full of marbles on the floor and they just spread all over. And traditional approach would be to count marbles within each tile because you have the boundaries. But it could be that the way this little marbles cluster completely ignores the administrative boundaries, and that's where these novel approaches can be used. And this is just two examples of this novel approach that basically untethers the investigator from the tyranny of administrative borders. Again, I'm not an expert in that. I do know that those methods are available. They're being constantly updated, and I would very much refer you to our upcoming speaker, Dr. Lance Waller. Grouping of cancers. So this is just one example. We know that there are specific genetic loci that transcribe specific proteins that have important role as cancer suppressors or oncogenes, and so mutations in those sites may produce a variety of cancers. So this is just one example of a G2C transversion mutation of TP53, which is a very well-known cancer-related gene. And as you can see, these mutations may produce breast cancer as well as several other cancers. So if one were to go after molecular features of a tumor, regardless of where it originated, chances are that our thinking about what cancers belong together and which ones don't will change. The same is true for, the opposite is true for cancers that we think is the same, but in fact represent a plethora of different oncogenic, different events. They have different etiologies, perhaps, and certainly we know that they have different outcomes, and they may be targets for different therapies. So, for instance, breast cancer is a breast cancer. If you look back, 20 or 30 years, there was no special way to understand how breast cancers differ from each other. And now we recognize, of course, that the molecular feature of breast cancer differ greatly. The triple negative breast cancer, for example, is one such molecular subtype that is quite different from other subtypes. For example, we know that alcohol is a risk factor for breast cancer. I think that there's no controversy there. But if you focus specifically on triple negative breast cancer, it does not seem that the alcohol plays the same role as it does for the majority of the cancers. I've looked at this issue relatively recently, and I think there is a dichotomy between the association that you observe for other breast cancers versus triple negative breast cancer. So chances are both the etiology as well as we know, treatment and prognosis differ, even though this seems to be a malignancy that originates from the same primary site. What about underexplored hypotheses? So again, the paper that I mentioned earlier, the 2012 paper, also looked at a long list of hypotheses that were postulated as possible reasons for clusters. And the great majority of them would relate to either radiation or environmental chemicals, sort of environmental health in a most common sense of it. Having said that, I think it's hard to argue that certain cancers clearly cluster in time and space. Leukemias is a good example. There is even some seasonality to leukemia occurrence. And what if we need to expand our hypothesis portfolio, so to speak, and start looking to other potential factors, such as population mixing, as well as potential infectious etiology of clusters. So this is just one recent example, just a couple of years ago, that looked at the clustering of acute lymphoblastic leukemia or lymphocytic leukemia in the state of Texas, and examined whether or not this clustering seemed to be associated with population mixing. And they found some support for that hypothesis. I think this is a potential direction for investigation, especially for clusters known to have, or not known, but suspected to have an infectious disease component that perhaps remains underexplored. They also talk about genetically transmitted rather than environmental mechanisms. Again, one study is never enough. One needs confirmation by multiple independently conducted investigation. Just an illustration that perhaps a useful thing to do would be to expand the plethora of hypotheses that are around when facing a cluster investigation. So I'm ready to conclude my talk. It's shorter than you may have expected, but I'm happy to answer questions either now or later on. So to summarize, if you go to 1990 special issue of American Journal of Epidemiology, and if you look at what people say these days, a lot of the challenges facing investigations of cancer clusters remain. We do have certain breakthroughs, and that specifically as they relate to various omic techniques, so molecular fingerprinting of cancers, as well as novel spatial analysis methods that may allow us to study clusters in ways that haven't been done before. The other thing is that our population data toolbox is filling up with new tools, and Nexus is one example where you can attempt to reconstruct not only present but past residential histories. And as I mentioned, they may be underexplored hypotheses that have been off the radar for many people who follow this issue. And with that, I'm ready to stop. I think my talk is ended up being really shorter than I thought, but that's okay.
Well, thank you, Mike, for a very interesting and stimulating talk. Appreciate it. And we just have one question already. I'll kind of try to summarize and relay them to you, if that's all right. So one person was asking, can you elaborate a bit on what you mean by population mixing in terms of disease clustering?
Yeah.
And I'll just add how that would fit into the cancer etiology part.
Yeah. So that's again, this hypothesis has been around for a while, but it seems to be underrepresented or we found it to be underrepresented in the. It started off with the I think it's called Sellafield cluster in the UK, where there was a concern that radiation from various military facilities in northern England and Scotland, I think, created clusters of leukemia. But then it turned out that some of the clusters occurred before the facilities were even constructed, or before the radiation began. There was any kind of even hint of radiation at those places because they haven't started operating yet. But what united them is that there was generally speaking, from the population point of view, these are isolated sleepy towns with stable population that have been there for several generations that experienced a sudden influx of newcomers from large cities because there were jobs and opportunities. And so that led several people, including Professor Kinlan, to hypothesize that it is the influx of the population rather than radiation per se that created this event. And the thinking went on, so it's still a hypothesis, but the thinking went on that people from large population centers that are entering this previously isolated communities bring with them pathogens to which the local population was underexposed. What these pathogens are is a different question, but this is what people mean by population mixing. So how one could test that hypothesis is to look at population influx into the areas of clustering as exposure of interest, so to speak. And with some regularity, there are reports that support that hypothesis, at least with respect to leukemia, as far as I know it. So that's, in a nutshell, that's the story there.
Okay, thank you. That was very clear, I think. A couple more questions came in. So the next one is, Do you have any comments on population size vis-a-vis statistical significance of studies?
Yeah, that's a very good point. I think we should probably abandon the p-value of 0.05, which has been the mainstay of a lot of these investigations, but instead look at patterns. It is not unusual to see, if you look at a variety of cancers across the board, it's not unusual to see that some cancers are elevated, but some are, the rates of some cancers are elevated, but some are lower than expected. And so perhaps the patterns may be a better way to look at what's happening in the community, as opposed to focusing on only those sites that have that demonstrated a increase in standardized incidence ratios with a p-value of 0.05 or lower.
And when you say patterns, are you thinking from cancer site or type to another site or type?
Exactly.
So how that goes across different sites and
exactly. I think it's a useful exercise to look at all of them.
Right.
Because very often what you will see is that there some go up and some go down.
Right.
On the other hand, focusing just on all cancers is probably not a good idea, because it ignores the biology of and heterogeneity of cancer sites.
Maybe it's an opportunity to use some of the groupings that you talked about too.
That's right. That's right. But again, assuming those data are available, but
yeah,
the data are increasingly being available, because a diagnostic workup for many cancers now includes molecular fingerprinting, so to speak. And so even if it's not, I don't know if it's available for a variety of cancers, but things like leukemias and lymphomas, for sure, you can really, if you can get your hands on really detailed clinical data, some of those pathology reports are exquisitely detailed.
Right. So another question was asking if you could elaborate more about investigative boundaries, the boundary issue, I think, for the cluster investigation.
Yeah, so here where I am a bit out of my depth, I will tell you right away. But there was a Dr. Bender from Minnesota Health Department. I think he also was at the University of Minnesota. And his argument was, you shouldn't be drawing the boundaries after you know where the cluster is. So you have to be somewhat agnostic. I'm adding to that thought, because if you do, then you already know there is an unusual event. So all of your statistical inference approaches are out the window, because you already know the answer.
Right.
Instead, what one can do is develop perhaps an agnostic screening statistical techniques where the cancer occurrence is being evaluated almost on a continuous basis. Remember, with this day and age, when we have rapid case ascertainment and the cancer registries receive data on newly diagnosed cancers almost in real time, I can see how one can develop a very interesting approach to regularly scanning the distribution of various cancers to identify hotspots, regardless of whether or not it happened in a given county or zip code. The problem is, if you perceive that, if you know that there is an unusual event, then drawing a boundary around that unusual event, it guarantees the answer.
Yeah, we used to
Bender, I think Bender refers to that as buying a lottery ticket after the winning number is known. And Rothman uses a less charitable a metaphor of a Texas sharpshooter.
I probably got mine from Rothman, because we used to call it the target phenomenon.
Exactly.
Where you throw a dart at the side of a barn, and then you can draw the target pretty accurately afterwards.
So again, with with modern cancer surveillance techniques and modern statistical approaches, there may be a way to just have this constant screening in place. But I would defer it to people who are experts in the field. I'm certainly not one of them.
Okay, well, that's helpful. So here's a kind of a similar question to the grouping question, but a little bit more detailed, I think. The question is, are you aware of available framework or guidelines for the purpose of cluster investigation? I think so. Some clustering based on genomic data. Sorry, the clustering. And if you're aware of any such guidelines, because the cancer registries and others might be open to using it. So
yeah,
question really is about existing guidelines for grouping and clustering based on genomic data.
So here's what I know. I know that the upcoming CDC guidelines that are still in draft form mention molecular fingerprinting of cancers, but I did not, granted, I may have not reviewed it in great detail, but have not seen them elaborate on that. They just bring it up as a possibility. So it will be a fascinating project, but I'm not aware of anybody who has actually done that. But I know that it can be done.
It feels like it, I don't know if it's done or not, but it feels like it could be the way people are now identifying tumors that are more or less susceptible to a particular new treatment.
Exactly. That's exactly right, Dana. So you always start with, not always, I shouldn't say that, but in my experience, we learn a lot by understanding the prognosis. That's how a lot of major breakthroughs happened in sort of not etiologic cancer research, but in the cancer outcome research. Prognostic as well as treatment. And so that's where people realize that different cancers may respond to the same treatment because they have common molecular targets for that treatment. On the other hand, we may have what seems to be the same cancer, but it does not respond. And so you almost go backwards from prognosis back to etiology. But the grouping, I think with certain cancers, lymphomas, leukemias, for example, there's so much work that's done during the diagnostic workup that you can perhaps recategorize those conditions rather than ALL, AML. Now, the problem that will occur, of course, is that the numbers will dwindle. Your sample size is going to melt away very quickly. But maybe it's maybe it's also a useful thing to know, because what may be perceived as a cluster is not. One of the CDC recommendations, of course, you evaluate whether or not the cancers that seem to be clustering together are too dissimilar. And if the molecular types of, say, several leukemia cases are very, very distinct, very different, it may offer information, even though that it will prevent you from doing a proper, let's say, case control study.
Right. Okay, well, another question that came in, adding on to an earlier question about investigation of boundaries for analysis. Can you speak of the challenges associated with the fact that clusters don't follow geopolitical boundaries, for which we have population, readily available population data?
Yeah. So, but we do have addresses. Cancer registries have addresses. Of course, it's PHI. So you cannot disclose those addresses, but the addresses are available, and those addresses can be examined using this agnostic approach that we discussed just a few minutes ago. And then you don't have to worry about zip codes or county lines or even census tracts.
Right.
You ignore the tiles on the floor, so to speak, and just look where the marbles tend to congregate.
Right. Good point. So another follow-up question, when looking at cancer patterns, it's related to the p-value issue, I think, somewhat. When looking at cancer patterns, how can we distinguish random variation without statistical testing? There's just too much temporal variation in small communities, is the comment.
Yeah. Yeah, I thought about it. You almost have to substitute the p-value with your own two eyes, and at some point just concede that there's so much noise that you don't see the signal. And I don't have a better way to put it in statistical terms, but if you just go by p-value,
I
I'm
can add
please,
a parallel.
I knew you would add something, Dana, to this.
I mean, there is frankly uncertainty in the incidence rate, in the standardized incidence rate, because of small numbers, right?
Yeah.
And that is the answer. I mean, it's not a yes/no answer, but the answer is here's the best estimate, whatever the best estimate is, and here's a range of values. And it's not yes, no, it's here's a range of values with ones with rate ratios closer to the estimate, probably subjectively being a little bit better than those way out. But I think, unfortunately, that is, that is a good way to summarize the data. And then some of the other investigations could conceivably proceed if the confidence intervals are pretty much excluding the null, which then makes it similar to a p-value. But one can proceed without certainty, I guess, without a definitive answer based on confidence intervals, I think. So it's not entirely perfect. It's not a yes/no, but it can be an accurate way to summarize the results.
Yeah, and then the other thing, if we use an agnostic approach for screening for clusters, in other words, the continuous reevaluation of the data, almost in real time, then each cluster does not have to be viewed as a one-off event. Because how do you combat small numbers? You try to replicate a similar experiment, so to speak, a similar study in different circumstances. And if, despite the uncertainty, the results seem to be pointing in the same direction, you have something going on. There's a signal as opposed to noise. Now, if you set it up that way, and if you see similar clustering in different places, then it may warrant a further investigation. How come they cluster? Part of the problems I see, and it's just my impression, is that each of those investigations are viewed as a one-off event that has no parallel to it. But it shouldn't work that way. I think if there is certain clustering that occurs in one place, you could expect a similar clustering to occur in a different place, assuming that they share etiology.
Right.
And so the broader screening / agnostic approach perhaps would allow to detect those seemingly disconnected clusters from each other, if those truly exist.
Mm-hmm. And we have a follow-up question about the boundary issue. Again, so if surveillance is based on boundaries, but you made the point that there can be residential information, but maybe not in surveillance. I mean,
surveillance reporting is based on boundaries. You would not report individual addresses, but remember the back end of it is addresses. How do you know that a certain person lives in Fulton County as opposed to DeKalb County? That's how you know, because you know their residential address. So surveillance reporting, you're absolutely right. There's no other way to present the data.
Right.
But it is a back-end information that can be analyzed.
Yeah, but that's more when the caution is out, right? When there's some caution or focus on a particular area, I guess, then you would start digging in with the residential history.
That's right.
So on.
That's right.
Then there's a question about correcting or adjusting p-values for multiple testing. For example, the Benjamini, if I'm maybe not saying them quite right, Hochberg, but there are others. Yeah, the FDR, the false discovery rate, right?
Yep.
This will not give you a definitive answer, but would help to characterize p-value results. I note that there does not seem to be much, if any, discussion of this in the new CDC guidelines.
Yeah. Again, I'm venturing into territory that's probably Dana's domain rather than mine. But
yeah,
there's certainly other approaches. You know, the Bayesian approaches, where you have some a priori expectations, right. And then those would dictate your guide your interpretation of observed results. I just feel it's awfully inadequate to just look at cutoff of 0.05 or 0.1, whatever people use these days, and just go with that. Now, the false discovery rate is one of, there's a variety of approaches. You know, people even do Bonferroni, which of course is a no-no.
It's quite
in many people's books, but nevertheless, you have to consider the possibility of multiple simultaneous hypothesis testing every time you do analysis.
Yeah. I do like the false discovery rate, the Benjamini Hochberg approach. I think can be quite useful, and a reasonable way to, when multiple comparisons is an issue or possible issue. Then I think that's a reasonable way to be thinking about things. Okay. Question about likelihood ratios. Let's let Lance handle that.
Yeah, let's punt it to Lance Waller.
Punt it to Lance, since that's his area. Let's see. Do we have any other questions at this point? I think we've covered the ones that I have here that have been relayed to me. So let me then, any last questions? We have a few more minutes here. Well, if not, thank you, Michael, Dr. Goodman, for your very helpful and useful presentation. And appreciate all your time and effort on